Hello, I'm Alicio Bautista, and I am the medical director for the Bariatric Surgery Program at Secours St. Mary's Hospital. I studied medicine at Loma Linda University in Southern California. Then I went on to my training in general surgery at Portsmouth Naval Hospital. At one of my first duty stations while I was in the Navy, I was at a hospital where another surgeon was performing a gastric bypass surgery. I'd never been involved with that type of surgery before, and as I got to follow up some of the patients, I was intrigued to see that many of their medication lists would get shorter and shorter or even clear up completely. Some things such as diabetes and high blood pressure were gone, and they were no longer needing to be treated for those. It was at that point that I realized that this operation really does have some value beyond making people fit better in their clothes or feel better. It truly has some medical benefit. Here at Secours St. Mary's Hospital, we have a program that has a 30-year history. We have 5 bariatric surgeons who have a total combined experience of almost 70 years. Between the 5 of us, we have performed over 5,600 procedures. Our hospital is a fully accredited center of excellence. We have specialized equipment for handling morbidly obese patients, and we have a dedicated bariatric surgery unit for taking care of patients post-operatively. In the operating room, we have state-of-the-art equipment to allow us to perform the advanced minimally invasive surgical procedures, including the use of robotic surgery. Obesity is a disease of metabolism with excess fat storage. It is lifelong, progressive, and life-threatening. Multiple factors come into play, including environmental, behavioral, and genetic factors. Strong genetic factors influence your body weight and may even influence your food choices. This leads to excess fat storage and multiple comorbidities or other diseases related to obesity. You may have heard your doctor mention your body mass index, or BMI. Your BMI is a measure of how much excess body mass or excess fat you have. The body mass index is calculated by using your weight and your height to combine it into one number. On this slide, you see various levels of body mass index. The higher levels correlate with increased risk of cardiovascular disease and other diseases. Here is a visual scale of the various levels of body fat. Interestingly, over the years, what used to be considered obese is now mistakenly referred to as overweight by the general public. Listed here are some of the diseases which are caused or aggravated by obesity. If you don't already have one of these conditions, your primary care provider has probably told you that you are at risk for developing one. You don't have to have all of these diseases in order to be at risk. Just being obese is a significant risk factor. As this graph shows you, increased body mass index correlates with higher risk of death. Hopefully these slides have convinced you of how serious this disease is, how important it is for you to lose weight in order to improve your health, improve these diseases, and prolong your life.
So what non-surgical treatments have been tried? Diets have been around for years, and we've learned that with low-calorie diets and very low-calorie diets, patients can lose about 10% of body weight gradually over 6 months. Unfortunately, nearly 95% of diets end in failure. Additionally, most patients experience the yo-yo effect where they regain more weight than they actually lost. Exercise increases the overall health and can allow burning of calories. For severely obese patients, it can be very difficult to exercise intensely and frequently enough because of orthopedic and neurologic issues present in many of the severely obese patients. Also, limited endurance can make exercise difficult, if not impossible. Behavior modification has been tried. These include programs like Weight Watchers, group therapy, one-on-one therapy, and even hypnosis. And while we learned that these can contribute to overall weight loss programs, by themselves tend to have limited success. They require a significant amount of contact time, and if patients lose or gain even a small amount of weight, it can be difficult to return to the program given the fear of ridicule or criticism. Several drugs have emerged to assist in medical weight loss. These include fat blockers, appetite suppressants, and newer medications which can control cravings and the way that we perceive hunger. We've seen upwards of 10% of loss of body weight, but these medications are limited in their value because insurance companies tend not to cover them, which can limit access to these treatments. Also, when patients stop the medications, weight regain tends to occur. This brings us to weight loss surgery, our most effective and durable treatment when non-surgical techniques have been unsuccessful. A new device was recently approved by the FDA to assist with weight loss, and this is known as the intragastric balloon. It is generally designed for patients with a body mass index between 30 and 40. It involves a 12-month program. The first 6 months, the balloon is inflated within the stomach, and this allows patients to feel full after eating small amounts of food. It also includes a supervised diet and exercise plan. After 6 months, the balloon is deflated and removed, but patients are continuously followed to evaluate their weight loss. The average weight loss was 26 pounds, and this did not involve stapling or cutting of the stomach. It is temporary, but it can be repeated, and there is a low risk of malnutrition. Some of the disadvantages include that it is not yet covered by any insurance companies, so it makes it a self-pay process. Early in the process, nausea tends to be severe in some patients. Frustration after poor results of medical weight loss are understandable, and it can be also understandable why patients would consider doing nothing. It's not always obvious, though, that the risk of doing nothing is higher than the risk of surgery in most patients. So who is a candidate for surgical weight loss? First, the NIH criteria are observed. What the NIH presented in 1991 was a recommendation for bariatric surgery for patients with a body mass index greater than 40 or a body mass index of greater than 35 with certain medical problems to include sleep apnea, high blood pressure, diabetes, or heart disease. Patient selection also requires the consensus of a multidisciplinary team, and this includes our surgeons, psychologists, internal medicine, and dietitian to prepare patients for the surgery. Patients need to be smoke-free to avoid later complications, and prior to proceeding with surgery, patients need to enroll in smoking cessation. Most importantly, patients need to be able to make lifestyle changes that allow the surgeries to work, and be willing and able to follow up with us to ensure good nutrition on your weight loss journey.
Now let's turn our attention to the various surgical procedures offered to treat obesity. These procedures are generally accepted and very popular as far as patient selection because of the great safety involved in choosing these procedures. They fall into two categories: restrictive procedures and malabsorptive procedures. I always like to give the example of the adjustable gastric band operation when we talk about restriction, because with the adjustable gastric band, or lap band as many people call it, there is a device placed around the very top of the stomach to restrict the size and capacity of the stomach. And this really is what restriction's all about, is limiting the stomach's capacity to hold food. So it's very focused on limiting portion sizes when you eat and reducing that capacity. The more popular current procedure for restriction is the vertical sleeve gastrectomy operation, or sleeve, which involves taking that stomach, which is a fairly distensible, large capacity organ, and making it into a narrow tube that doesn't hold very much food. When we talk about malabsorption, and here we get into talking about the Roux-en-Y gastric bypass, or the bypass, as many people call it. Here we're talking about bypassing a portion of the small intestine, and what the small intestine does is absorb calories. So when you bypass part of the small intestine, you decrease the absorption of calories and also some vitamins and nutrients. So patients who have Roux-en-Y gastric bypass need to take vitamin supplements after the surgery. So let's pause for a minute here and look at the normal anatomy and talk about that for a moment. The digestive system starts with a tube called the esophagus, which connects the back of your throat to your stomach. The stomach then connects to the small intestine and then leads to the colon, and then the rectum, and defecation occurs through the rectum. What you may notice is that the only really distensible organ is the stomach. The stomach was designed and useful in evolutionary time, like caveman days, to hold food when food was available. Now think back to those times in our development with our ancestors. Food was not plentiful. So there were times when no food was available, but when food was available, it was very important that people could eat whatever was available. And this is probably the explanation for why we have this distensible stomach. It may be something that's really outlived its usefulness, because today we have processed, invented foods. We have food scientists whose job it is to create food that we can't resist, that's high calorie. So this distensible stomach may actually hurt us in the modern era compared to what our ancestors dealt with. The most common nutritional disease in the world used to be starvation. Now the most common nutritional disease in the world is obesity. Now we'll delve into a little more detail about the procedures that we've had that introduction. I like to start with the adjustable gastric band operation because it's pretty simple to understand. Here a device is implanted and wrapped around the very top of the stomach to make a small pouch. The idea is that this very small pouch fills with ingested food and then takes a while to empty. Now that can be adjusted by inflating the band to make it tighter. And that is done through what's called a port, which is a device implanted under the skin in the abdomen that's accessed with a needle. There are some positives to this procedure. There's no rerouting of the GI tract when you do the adjustable gastric band operation. And frankly, the studies have suggested that this is a pretty safe operation, with a couple of exceptions. Number one, it's turned out to have extremely variable weight loss. The hopes were that this very simple approach would have great weight loss results, but actually only about 20% of patients reached the weight goals that they had set for the procedure. And then the other problem is that reoperative surgery is often necessary. Up to about 50-60% of patients ultimately end up with more surgery, particularly because they never lost the weight that they'd hoped to lose. This is a video of the procedure and how the procedure is performed, just very simply showing that the device is wrapped around the top of the stomach in position to make that very small stomach pouch at the bottom of the esophagus. Remember, the esophagus is that swallowing tube. And then once the food passes through the band, it empties into the rest of the stomach. So there's no rerouting of the intestine, no cutting, no stapling of the stomach, etc. So this procedure is also quite reversible. In other words, surgery can be done to remove the device if there's a problem. This shows how the band is adjusted, and what you're looking at is the port. Remember, that's the portion of the device that's placed under the skin in the abdominal area with a needle put into it to add fluid or remove fluid in order to either tighten or loosen the band. And this is a procedure that's often done in the office or sometimes in the X-ray department under X-ray guidance if needed. And this allows us to restrict the patient more or less depending on the circumstances. At this point, I always like to emphasize that a needle is used to do this because, believe it or not, occasionally a patient will not fully understand that a needle is used and then report to us that they're terrified of needles. So if you're a patient who's terrified of needles, this is not a good procedure for you. The other problem with the lap band is how often patients need to come in for treatments and adjustments. The procedure that has really replaced the lap band today in modern bariatric surgery is this sleeve gastrectomy operation.
The next surgery to discuss is the sleeve gastrectomy. This procedure is done laparoscopically. It is designed to remove 85% of the stomach. It is a restrictive procedure, which means it makes the stomach smaller so that you eat less and feel full after a small meal. In addition to the mechanical effects of making the stomach smaller, by removing a portion of the stomach, there's less hormones that are produced by the stomach, and so we believe that helps with decreasing hunger and leading to more weight loss. The surgery is unique in that it is not reversible. This is a permanent change. We have to staple the stomach along its entire length, creating a hollow organ with no output. So we do have to remove a portion of the stomach that can never be put back. The advantages of this surgery is it does not require an implantable medical device. It does not require frequent visits for adjustments like the lap band. Weight loss is very good, with patients losing 1/2 to 2/3 of their excess body weight. The surgery can be performed at low risk. One of the questions we get frequently from patients is, why did this surgery come along later after the lap band and the gastric bypass? It has to do with safety and our ability to staple the entire stomach from beginning to end with a leak rate less than 1%. It took till about 2007 to have that safety margin, and that is why this procedure came along later. Now I'd like to share a video with you of how the surgery is performed.
This educational video will explain the normal process of digestion, the sleeve gastrectomy procedure, and how weight loss will occur upon completion of the surgery. Currently, your stomach can hold about 40 ounces of food. Once in your stomach, the food combines with digestive juices containing acids and enzymes that help break it down into smaller particles. Once broken down, the small particles are slowly released into the first part of your small intestine, the duodenum, by a muscle called the pyloric valve. The pyloric valve is a ring of muscle between your stomach and your duodenum. Most of the nutrients from the broken down food are absorbed in the duodenum and the jejunum, which is the second part of the small intestine. There are 3 main steps in the sleeve gastrectomy. The first step is disconnecting the tissue between your stomach and your abdomen. The second step is dividing your stomach into 2 sections. The third step is removing the upper rounded left part of your stomach. In the first step, tissue between your stomach and your abdomen is disconnected. Your surgeon will separate the tissue that connects the left side of your stomach to your abdominal organs, such as the spleen and the colon. The second step is dividing your stomach into 2 sections. Your surgeon will divide your stomach using an endoscopic stapler. Your surgeon may also use traditional stitches or a combination of both staples and stitches to seal each section of your stomach. This seal is called the suture line. The third step in the sleeve gastrectomy is removing part of the stomach. Your surgeon will remove the left part of the stomach, which includes the fundus. The fundus is one of the areas of the stomach that produces the hormone that controls your appetite. The remaining portion of your stomach will be about the size and shape of a banana. Once you have healed from the surgery, weight loss will occur because of 2 reasons. First, your new stomach size will force you to decrease the amount of food you can comfortably eat. Secondly, the sleeve gastrectomy will cause your body to decrease or eliminate the release of a hormone that stimulates the appetite.
And now I'll be talking to you about the gastric bypass. The gastric bypass, the formal name is the Roux-en-Y gastric bypass. This is, of the surgeries that we do, certainly the most established surgery. It was developed about 50 years ago by Dr. Mason. This surgery is probably actually the most common bariatric surgery done nationwide. And this operation works through a few different methods. The first way this operation works is by restricting the size of the stomach. Basically, we make your stomach much smaller. Your stomach can hold about a few ounces of food at a time. So when you eat a piece of food, it comes down and fills up into your small stomach. You feel full and you stop eating. The second way the operation works is by malabsorption. We reroute some of the intestines. We shorten the intestinal length by doing the bypass portion. So we have about 150 centimeter roux limb or bypass portion of the intestine that makes your absorption different. You don't absorb as many nutrients from the food that you ingest, so you don't absorb as many calories from the food that you eat. So that's another way it works. The third way it works is also hormones. There are different hunger hormones that are secreted by the intestines, those two being leptin and ghrelin, and those work to affect the brain and tell you that you're hungry. So after surgery, the hormones leptin and ghrelin are significantly decreased, causing more weight loss by not feeling as hungry. Now, after surgery, there are things that change. You'll be eating smaller portions much more often. You'll be eating a much higher protein diet after surgery. Low carbohydrates. If you eat too many carbohydrates, some like a sugary load like a cupcake or something like that, you can get potentially dumping syndrome. Dumping syndrome is where the high carbohydrate load can't be handled by the stomach, and your stomach flushes fluid into your intestines, causing crampy abdominal pain and diarrhea. The advantages of this surgery is that it definitely gives you the most weight loss of the 3 surgeries that we perform. The weight loss with this operation is about 70 to 80% of your excess weight lost long term within about 10 years of surgery. So it has the best results in terms of long-term weight loss. It also has a very profound effect on diabetes and is one of the hottest areas of research in bariatric surgery. We find that our patients who are diabetic are generally off or on reduced dosages of their diabetic medications within weeks to months after surgery. This is certainly a great operation for patients who are on maybe the higher end of the BMI scale or the weight scale and diabetics. Now we have a short video to describe actually how the procedure is performed.
This educational video will explain the normal process of digestion, the Roux-en-Y gastric bypass procedure, and how weight loss will occur upon completion of the surgery. Currently, your stomach can hold about 40 ounces of food. Once in your stomach, the food combines with digestive juices containing acids and enzymes that help break it down into smaller particles. Once broken down, the small particles are slowly released into the first part of your small intestine, the duodenum, by a muscle called the pyloric valve. The pyloric valve is a ring of muscle between your stomach and your duodenum. Most of the nutrients from the broken down food are absorbed in the duodenum and the jejunum, which is the second part of the small intestine. The steps in the Roux-en-Y gastric bypass involve dividing your stomach into 2 sections to create a smaller stomach pouch, dividing your jejunum into 2 sections, creating a Y connection between both parts of your jejunum, and creating a connection between your stomach pouch and jejunum. Your surgeon starts by using an endoscopic stapler and divides your current stomach about 1 to 2 inches below the area where your esophagus connects to your stomach. The smaller upper section of the stomach that is connected to the esophagus is your new stomach, also known as the gastric pouch. This gastric pouch will hold about 2 ounces of food. Next, your surgeon divides and seals your jejunum into 2 sections. Your surgeon will take the shorter part of your jejunum and reconnect it to the longer part of your jejunum at a point further below the point of division. Next, the remaining part of your jejunum is pulled up and attached to your gastric pouch. Food will now go from your new stomach pouch directly into your jejunum. Prior to surgery, food went from your stomach into your duodenum. Your duodenum and a small part of your jejunum are now bypassed and will not come into contact with any food. Because food bypasses the duodenum and part of the jejunum, fewer calories are absorbed.
Here at Secours St. Mary's Hospital, all of our surgeons use minimally invasive surgical techniques to perform bariatric surgery. This is a robotic surgical system that allows these procedures to be performed with greater precision and less trauma. The Da Vinci surgical system provides greater flexibility. The instruments function much like your wrist does to give you better precision and greater dexterity.
Bariatric surgery is major surgery, but it has become remarkably safer over the years. For gastric bypass and sleeve gastrectomy, the overall complication rate approximates 15%. Staple line leak, the complication we worry about the most, is far less than 1% in its incidence. With gastric banding, the overall complication rate is approximately 12%, and this includes a 1% risk of the band eroding into the stomach. Bariatric surgery, as it has evolved into a safe and commonly performed operation, now has risk of death far less than 1% and has proven itself safer than many other commonly performed procedures. When we look at patients who undergo bariatric surgery compared to those who do not, the surgery patients experience a significant reduction in their risk of death over the years as their overall health improves and their medical conditions are better managed.
So now let's review the key features about the various procedures and talk a little bit about decision making with procedure choice. Remember, we've talked about 3 procedures, 2 of which are restrictive, the adjustable gastric band operation. Now that operation is a very safe procedure, but it has very variable results in terms of weight loss, and it's really fallen into disfavor around the world because of this variability in weight loss results. After all, you're making a decision about surgical treatment and you'd like to see the results you're looking for once the procedure is over, and this procedure provides too much variability for most people. We do use it selectively today. We actually prefer, if you have any interest in this procedure, that we get you into the office and talk one-on-one about your interest to see if we can predict it'll work for you, so bear that in mind. Now, the sleeve gastrectomy is the procedure that has really replaced the band and become the #1 most commonly performed bariatric operation both in the United States and around the world. This procedure has good weight loss. 50 to 65% of excess body weight can be lost with this procedure. It does not require frequent office visits for band adjustment like the adjustable gastric band. And there are no needles to adjust anything. There's no foreign devices put in the body with the sleeve operation. Remember, this operation is not reversible because we remove about 85% of the stomach in order to create that narrow tubular stomach. And then we have the gastric bypass. And I want to say a few words. Not only is this the gold standard, but in particular, I think it's important that certain groups of patients think seriously about this procedure as an option. For one, because there's more weight loss associated with the gastric bypass, it actually makes more sense for the very heaviest patient group. So patients who have a lot of weight to lose, maybe several hundred pounds, would be better served by an operation that provides more weight loss in order to get back to good health. The other population that's extremely interesting to talk about is the diabetic population. Gastric bypass has a special effect on diabetes that's really quite remarkable. We typically send patients home from the hospital off all of their diabetes medications within 1 to 2 days of surgery. This phenomenon seems very specific to gastric bypass, affecting your body's ability to be sensitive to insulin. And this is very important in the treatment of diabetics. The success rate for diabetes treatment is much higher with gastric bypass than with the other procedures. Another type of problem that people have that it's similar to diabetes is what's called gastroesophageal reflux, similar in that gastric bypass is a better treatment for gastroesophageal reflux disease than either the adjustable band or the sleeve gastrectomy. Gastric bypass has been called the most successful operative procedure that can be done to treat reflux disease. And here we're talking about heartburn, regurgitation, that foul-tasting fluid that sometimes comes up in the middle of the night. People who suffer from those types of problems, gastric bypass both gets rid of the bile completely that could reflux and also greatly reduces the acid that can reflux. So patients who have GERD or gastroesophageal reflux disease should probably strongly consider a gastric bypass as the best procedure for them. When it comes to the results of bariatric surgery, we have to talk about a variety of things that can be measured. We've talked a lot about weight loss today and how much weight people might lose with surgery, but it's also important to realize that improved health and improvement in what we call medical comorbid conditions, things like diabetes, things like sleep apnea, high blood pressure, heart disease, even the risk of cancer is dramatically reduced with successful weight loss through surgery. And then, of course, there's increased survival and longevity. That has been shown by every study that has ever compared bariatric surgery treatment to no surgery treatment for obesity. Surgical patients live longer than patients who've not had surgery. And then, of course, the quality of life that's so important. Health, social quality of life, personal quality of life, getting away from discrimination in the workplace and in your social life. All these accompany successful weight loss and are some of the more positive results that we see with bariatric surgery.
Next, we'll discuss some questions that are frequently asked by patients when considering weight loss surgery. The first is, what results can I expect after surgery? To begin with, you can expect that you will lose weight, have reversal or decrease in the side effects of obesity or the comorbidities. It can improve your quality of life, and it can lead to a longevity of life. On average, weight loss is anywhere from 40 to 60% of your excess body weight. You can see about an 80% reduction in comorbidities such as high blood pressure, diabetes, and sleep apnea. There's about a 20% decrease in overall mortality after the surgery, and quality of life measures can be profound. Second question is, how long will I be in the hospital? This varies with procedure. With the lap band, it is outpatient or overnight. With the bypass, 80% of patients stay one night. The remainder go home after a second night in the hospital. The sleeve falls in the same category of about 80% staying one night and the remainder staying for 2 nights. The next question, how long will I be off from work? In general, 1 to 2 weeks before you can return to light duty, such as a desk job. As for strenuous activities such as heavy lifting, strenuous pushing or pulling, or other physically demanding work, we typically say wait 4 weeks before returning to those types of activities. How long does the actual surgery take? Well, for the lap band, it's about an hour, and the sleeve falls in about at an hour as well. The bypass, you can anticipate about 2 hours in the operating room. Will I throw up all the time? No, we hope you don't. All surgery on the digestive tract can cause nausea and vomiting. It's usually temporary and self-limiting. If a patient does develop frequent nausea and vomiting, then we need to investigate that to find out if there's something wrong and correct it. Will I have diarrhea all the time? Diarrhea can happen with dietary changes and can be easily controlled with modification of the diet and eating frequently and following a diet diary to eliminate the things that might be causing loose bowel movements. Will I have to eat baby food all the time? Absolutely not. These surgeries all make your stomach smaller, so in the beginning, the meals are either liquid or pureed. But after about 2 weeks, you should start to be able to eat solid food. We try to design any weight loss surgery to allow you to eat a wide variety of foods after you've recovered from the surgery completely. Can I get pregnant after obesity surgery? The answer is yes, but we recommend that you wait about 18 months after the surgery so that your body adjusts to the changes that have occurred with the surgery. Is surgery dangerous? All surgery has risks, but bariatric surgery these days, the risks are about equivalent to the risk of having a normal delivery. The risk of death is less than 0.1%, and the risk of complications is in the 10% range. Can the surgery be reversed? For the band and the bypass, the answer is yes, but it is not done frequently. For the weight loss to be permanent, typically the surgery needs to be a permanent change. For the sleeve, we cannot reverse that surgery. It is a permanent change.
So there are a number of different questions you might want to ask your program. First question you might want to ask is, are they a center of excellence? At Bon Secours St. Mary's, we are a center of excellence with the highest accreditation. You might want to ask about how many surgeries a program does a year. Generally, the more surgeries that a program does, generally the better results they get. Weight loss results. You want to talk about their long-term results, short-term results. Complication rate. What might I expect after surgery as far as complications? What is the complication rate of the program? You want to talk about support groups. Does your program have a support group? How often do they meet? At St. Mary's, we have a monthly support group that meets to help our patients stay on track with their weight loss goals. And then also, do patients come back? Follow-up care is very critical to having good results long-term. And we here at our St. Mary's group want to make sure that you are our patient forever. We want to follow you every year after surgery to make sure that you are staying on track. We want to make sure that your success as a patient is our success as a program. We want our patients to do very well with their long-term goals.
Hi, my name is Jenna Schmidt, and I'm a registered dietitian with over 8 years of experience working with surgical weight loss patients. Our nutrition program includes the following. We offer pre-op nutrition evaluations, and this is where we will help you to make changes before you have surgery. We also do supervised weight loss classes, which will help you to qualify for insurance approval. We also offer post-op nutrition counseling. This is where you will learn how to maintain your weight loss long-term. We want you to be successful. Your success is our success. So there's a lot of components to success. Yes, there's surgery, but there's also making healthy food choices, increasing your activity, managing your stress, and attending support groups, which we host here at the hospital 2 times a month. It will be important for you to learn a lot about nutrition before you have weight loss surgery. One of the most important changes is making sure you understand the basics about fluids. It is important for you to be able to consume at least 48 ounces of fluid a day after surgery to maintain hydration. You will learn to drink fluids between your meals and stop drinking 30 minutes before and after your meals. We will teach you to sip your fluids and not gulp. You will also need to limit caffeine and avoid carbonated beverages. And you will not be able to use a straw after surgery. Protein will be very important to your weight loss journey. Maintaining lean body mass, helping you to heal are some of the reasons why protein is so important. It will also help you to minimize hair loss and maintain your energy level. We will teach you about the types of foods that give you protein and help you to achieve your daily goals of 60 to 80 grams each day. Things such as low-fat dairy, such as cottage cheese, yogurt, also eggs, and even things like chicken, turkey, deli meats, lean ground meats, and fish. Beef and pork are typically not recommended as they are too fibrous in the beginning stages after surgery. It will be crucial that you use protein supplements in the beginning stages after you have surgery. These protein supplements will help you to meet your daily protein goals. We will teach you how to purchase these types of products. It will be really important for you to take vitamins for the rest of your life after weight loss surgery. This list shows you just a few of the vitamins that you will have to take, and we will guide you on exactly what you need to take closer to the time of surgery. These are just a few of the basic eating principles that we will teach you in your pre-op nutrition classes and help guide you in your post-op nutrition appointments. Exercise is going to be key to your success long term, and we know everyone is at a different starting point. So we do have programs to help you get started. It will be important for you to be active in whatever way that may mean for you. It can include strength training, stretching, or doing activities such as walking, getting your heart rate up. Aiming for 30 to 40 minutes 5 times a week is the ultimate goal, but we know everyone starts off slow. Even if you can do a 10-minute walk 3 times a day, that's a good starting point for a lot of people. It's important to have fun with your exercise regimen and to make better choices, such as parking farther away or taking the stairs instead of the elevator. Every little bit of movement helps, and it'll get you closer to your ultimate goal. There are several programs available to you before and after surgery to help you get started with exercise. It's important to know how to get started. You don't want to injure yourself. It's also important to feel comfortable. A lot of people are intimidated by gym settings. So these programs can really help you to get started and individualize your exercise goals. You can use these programs to help to create a routine that you can follow at home or in the actual gym setting. It can help you to prevent injuries and takes into consideration your physical limitations. We can also help you to just get motivated. So here's what you can do to get ready. Start weaning off the caffeine. I know it's hard, but if you can just start limiting a little bit each day, you'll eventually get there. Stop smoking. Try to work on eating 3 meals a day. This is really, really important to lay the foundation. Eat slowly. Start sipping your fluids instead of gulping. And just get out and start walking. Every little step will get you closer to where you want to be.